you guys can hear us. All right, everyone, welcome to the Health Hub with Dr. T. As you know, I'm Dr. T. We also have another Dr.
I
T
know.
on here today. As usual, I give my disclaimer. Anything heard on this live or on this page is general information only. If you want more information, if you have specific questions to your health or the health of your loved ones, please feel free to reach out to your healthcare provider and ask them for the appropriate referral, and they would be more than happy to do so. So I just want to put that disclaimer out there today. So today, y'all, she's a big deal.
Ugh,
Like, I
stop.
know, I feel like I've known you, but like, you're a big deal. And so I want to give you that opportunity to just introduce
Uh,
yourself, your credentials, and just what you do on Mondays,
you are
surgeries, things like that.
hilarious.
If
You
you
are
can give us a
hilarious.
quick introduction of who you are.
Wonderful. But first, thank you so much for the opportunity to be here and even for creating this platform. I really admire that you can do this. It's not easy, but it's so important for all of us to be talking about our health, especially because there are things we can do about it. And of course, again, thanks to the audience for joining. I know everyone's busy, but really appreciate them taking time out to join us. But so my name is Dr. Taiwo Adesoye. I'm a breast surgical oncologist, which just means I'm a surgeon who performs surgery on the breast for any breast lesions, but most importantly, breast cancer. I also do research on breast cancer where I work with people in the lab to try to understand why some people's tumors respond better to systemic therapy or treatment in general. But yeah, like she said, my I do surgeries. Like Monday's my OR day. I see people in clinic and plan their surgical plans and talk with other healthcare providers to get patients the best care for them.
Awesome. Thank you so much. I mean, for just what you do. I know it can be easy. And so on this end, we really do appreciate you all that are learning more in the research world, trying to understand more, really truly saving lives day to day. And I want to also kind of give another disclaimer that this conversation we're about to have is super sensitive, right? Even when I was mapping out what the end of the year would look like. And I kept thinking October, but I kept bypassing October and going, oh, I know what I want to do for Thanksgiving. Or I know who I want to bring on for September because the C word is so scary. Like, I don't know how else to say it. I have loved ones who's had it, who have it. I mean, it's just I know people and I almost feel like almost everyone knows someone or has known someone who's had cancer. So this conversation I know is super sensitive to everyone. And so I do want to put that out there. We may say certain things or we may smile, we may joke, but that doesn't take away from the seriousness and the sensitivity of it all. So thank you so much for just doing this. Like, truly appreciate you trying to or furthering the knowledge of those of us who want to learn more and want to know more. So with that being said, I want to start off with something you and I kind of talked about when we talked about this live is for those who I would say does not have cancer, does not really know, have experienced cancer or have dealt with it with a loved one closely. They may feel like, oh, this life is not for me. I don't need to know anything. There's nothing I need to do, or there's no signs or symptoms, or nothing I need to prevent in order to not get there. What do you say to things like that?
Right. So, Breast Cancer Awareness Month is October. So
Yes.
it's so timely that we're having this conversation. And I know, in the last few, years, I've had to essentially serve as a guide to friends and loved ones as they navigated their own cancer journey, particularly breast cancer. Nobody thought they would get it. I didn't think any of my friends would get it or their parents or
Mhm.
anything like that. So I think it's incredibly important for everyone to be familiar with breast cancer. It's very common. The numbers we quote in the US, it's a 12% lifetime risk, meaning
Wow.
1 in 8, women will get breast cancer.
Wow. Wow.
And so that is a big deal. So
Right.
again, it's very common. And it's not a one size fits all sort of risk, right? Which is brings me to my first point. You need to know your risk of breast cancer.
Right.
So the number I quoted is high, but that's actually just the average woman, right?
Wow.
Now, there are specific people that are at higher risk for breast cancer. And it's
Mhm.
important to know if you're one of those people, because then we start to do things a little bit differently.
Yeah.
So, first of all, everyone, women, also for men, it's actually important because men too can get breast cancer. Okay.
Right.
Um, but mostly for women, having the conversation with your primary care physician from the age of 25, some people with their OBGYN, and start saying, how can we, investigate my risk? They can do it several ways. They can ask you questions about your family history. We don't always, talk in our culture, particularly about, you just hear someone died of something. You don't really
Right.
know what they died.
Right. Right.
But it's
Right.
critical to know this information because if
Mhm.
someone passed from breast cancer or had breast cancer, it could be genetic, it could run in the
Mm.
family. And that's part of the information that a healthcare provider will help you tease out. They may also refer an individual for genetic counseling, which,
Mhm.
if you're, depending on your risk profile, they may be able to see if you actually have a genetic mutation. The other thing they can do, and this is why it's so important to know your risk, we can prevent and treat early breast cancer. The way we do that is if someone is at higher risk, we can ask them to start screening early and we can give them medicines to reduce their risk of developing breast cancer.
Oh,
That's
wow.
why it's so important to let your GP know, let your OBGYN know that, hey, I'm interested in understanding my risk. There are risk calculators they can use to also determine, if someone is at high risk of breast cancer. And so
Mhm.
essentially all that helps put things into perspective. Should this person start screening with the mammogram earlier than age 40, which is what is recommended for the average woman?
Right.
Two, does this person need to be screened with a particular type of imaging? There's mammography, there's also MRI, there's ultrasound. And then three, does this person need to be on medications to prevent a certain type of breast cancer? So
Wow.
I'll leave it at that.
So that's, I mean, I didn't even know that you could prevent when I say, yeah, that you could prevent it, if I'm being honest and transparent, right? I just hear of, okay, somebody in your family history, okay, that's fine. If you start having signs or if you feel a lump or things like that, then they can start treating it. But I wasn't aware that even if you have a family history of it, and you speak to your, your OBGYN or the appropriate healthcare provider, they can actually start from, all right, you're getting closer to this age, maybe you need to be on some kind of medication.
Correct, correct. And
Wow.
even beyond medication, there are other
Hmm.
things that we can do. So we know some things are associated with developing breast cancer. There's some things we can change. There's some things we can't change, right? The
Okay.
things we can't change, your age. The older you
Mhm.
grow, the higher the risk of developing any type of cancer, in fact.
Cancer.
And then two, being a woman, you're going to have a higher risk of breast cancer compared
Right.
to a man, period. So those things we can't change. But there's some lifestyle and environmental factors we
Mhm.
can change. I know we all like our little drinks every once in a while, like alcohol, but I'm telling you, it has been associated with the risk of developing breast cancer. Obesity,
Really?
yeah, correct. Even a glass a day, and so there's guidelines out there that really minimize the alcohol you're taking, and if you should be taking alcohol at all. Um,
Wow.
Limited physical activity. We know a sedentary lifestyle can increase your risk of developing any type of cancer. We do know some cancers are some people are at higher risk of developing cancers if they're obese. So watching your weight, it's not just to look good.
No.
Watching your weight can really help with preventing breast cancer. And so that's why we always encourage activity. Again, adjusting your lifestyle. And then, sometimes some women have just, been exposed to estrogen longer. So if you started
Mhm.
your menses early, women that have not breastfed, we do see that they have a higher risk of developing breast cancer.
Wow.
Women that have not become pregnant, even as they grow older. Again, these are all things that sort of expose you to estrogen for a long time, and so that's why we say women should just have these conversations with their GP
Right.
so that they can know their risk and start to do something about it.
Wow, that's interesting though, meaning that, I guess I didn't think about when people ask, even when my OB asked, when was my first cycle? I was like, I don't know. Like I remember this situation because my parents were like, "Oh, now that you've gotten your cycle, if a man touches you, you get pregnant." And like same day, my brother hugs me, and I was like, "Oh my God, I'm pregnant." Obviously not, but I don't even I was trying to sit back. I recently saw my OB and I was trying to think back to the age and I couldn't, but like now I'm really going to like go back and see like how early did I start it, because so what you're saying is the longer estrogen has been in your body, you're more likely. So if you've had a baby or if you have breastfed, or let's say you started your cycle a little later, you were able to kind of get out some of that estrogen.
Well, it's just, yeah. So it's
The
your
balance.
estrogen. It's not being produced in that in
Okay.
those scenarios that you just mentioned,
Okay.
and so that's why those things we see in studies are associated with having a higher risk of
Hmm.
breast cancer. That's because so there are different types of breast cancers. I won't go into the details, but some
Right.
of them, the most common ones, it's responsible for about 70% of breast cancers are driven by a high estrogen state, or they're just driven by
Mm.
estrogen, period. They have these little receptors on there that estrogen binds to, and the cells just go crazy. That's my simplest explanation of cancer: crazy cells. They're cells
Mm.
that just go crazy and they keep growing and they don't stop
Wow.
growing. And
Wow.
so it's the majority of breast cancers can sort of be driven into this state of overgrowth by estrogen. That's why estrogen really matters.
Mm. Okay. Wow. Child, I'm about to go look up estrogen when I get off this live now and learn more. We have a question. So sometimes I may dip in some questions because
Of course.
sometimes the questions get really, really full, and I want to make sure that I get to
Sure.
it. Niger underscore Lebanese says, when you say prevent, are you talking about a prevention before it even shows, or at the level of chemo?
Before it even shows. So there's some patients that they sometimes, right, they already have a high risk lesion, something that we already feel like it may predispose them to cancer, even though it's not cancer. We
Right.
put these patients on anti-estrogen medication. So it's called chemo prevention. It's not chemotherapy, but it
Okay.
just blocks estrogen.
Okay.
Okay. And so that's what yes, there are some scenarios where you can take medicines to prevent breast cancer, but it's only if your risk is high enough.
High. So what do you consider high? Is consider high like let's say it's a parent, it's a loved one, it's a cousin, distant cousin.
Right,
What
right.
is considered high? I know there's so many criteria to it. It's not just one or two, but what are some criteria that would make someone be high for that?
Yeah, so they have actual calculators that can
Oh.
help determine these things. So these calculators contain information about, your age, your current age, any family history. If you've
Mm.
had a breast biopsy for any reason in the past is also factored into this. And so there's just information that these calculators pull. And what we consider high risk is a lifetime risk that is 20 to 25%. So that's
Wow.
higher than the
That's
average of 12%, right, that we
right.
quoted earlier. So that is the precise definition of high risk.
Oh wow. Okay. That's interesting to know. So anyone can go to their OBGYN and be like, "Hey, I would like to calculate how what my
Yes,
risks are."
yes,
And they would
yes,
know exactly what we're talking about. They would kind of go to
correct.
our screening and
Yes,
actually let us know where we stand. Okay.
correct, correct.
That's good. There are no stupid, silly questions. Niger underscore
Oh,
Chloe. None. Because
not at
if
all.
please, because I'm probably gonna ask a lot of different questions. So she said, this might be a silly question. Does chances of cancer reduce after menopause due to low estrogen?
That is actually a phenomenal question.
Question,
And
right?
so it's a balance, right? You are absolutely
Mm.
right. You would think oh, I'm no longer making estrogen with my ovaries, I
Right.
shouldn't have cancer, right?
Mhm.
However, there's fat in your under your skin in your body that, we talk about obesity related breast
Yes.
cancers. There's fat there that still make estrogen, and then by virtue of just being older, your cells are just less on point,
Yeah.
if
Yeah.
that makes sense. And
Right.
so that combination actually increases the risk of getting
Mhm.
breast cancer as you're older. However, the types of breast cancer that older women get are less aggressive. They're not as
Okay.
aggressive as the ones that younger women get. They're
Wow.
incredibly treatable. A lot of the times they just get surgery and they take this anti-estrogen medicine for several years, and they're essentially cured. In
Wow.
fact, we've been able to pull back on some treatments in older patients because we realize their cancers are just lazier. They're not as
Aggressive.
aggressive as the ones we see in younger women.
So obviously, no one wants it. No one, no one. However, if we were to get it, we want a long age because
Hmm.
at that point, it's just sit it there. Those cells don't replicate as quickly
Great.
because
Yeah.
but the same thing with like as a PT, your muscles, your nerves, all of that. It's not as agile as you
Hmm.
get
Hmm.
older,
Yeah.
right? So
Yeah.
it's almost like okay, so that makes a lot of sense. Oh,
Yeah. Yeah.
I know it sounds that was a really good question because a lot of our generation, right? I'm really my audience is that sandwich generation where we have our parents are getting older, we have young kids, so we're at that age where it's kind of like we don't, people are going to get mammograms for the first time. They're going to see the urologist, prostate, all of
Yeah.
that. So
Yeah.
I really think this is really vital for our generation right now. So okay, thank you for that. Another question. Are there preventatives safe? Many preventatives have been known to act as exposing you to what you are preventing. If if I in fact had no chances, but I think I may take it, what are the risks? So are the preventatives for I guess I get what he's saying. The medication that could prevent the cancer, are those safe or would they expose you more to the cancer? Correct me if
So
I'm wrong, but I think that's what you're
I
saying.
think that's what they're trying to say. So I
Okay.
know everyone sort of balks at the idea of taking medicine. People are
Right.
just scared of taking medicine.
Right.
I don't want stuff in my body. And medicines, they're not perfect. They do
No.
have adverse events or side effects. That is sort of just par for the course for any
Mhm.
type of medication you take. Now, some of the medication for prevention, they can predispose someone to a higher risk of, things like blood clots.
Right.
Sometimes, there's also a small risk of uterine cancer with it.
Mhm.
So absolutely, these are all things that will be discussed with you in the backdrop of the risk of getting breast cancer.
Cancer.
Okay. And so those are sort of the conversations that end up happening. It's not that it's not something to shy away from. And I think we really have to get into the frame of mind where we are understanding risks and benefits. There's two
Right.
sides to the coin,
Mhm.
and not be too afraid of just putting something in our bodies, but recognizing that these things have value, but
Mhm.
still understanding that risk benefit. Now, if someone has a mutation, a genetic mutation that is discovered, and it's very clear that this runs in the family, one thing we may recommend is surgery, where the
Okay.
woman removes the breasts. Um, they may also recommend removal of the ovaries because in the most common genes that are that give rise to breast cancer also affect women's ovaries and can increase an individual's risk for ovarian cancer. So
Okay.
sometimes you have even young women that I operate on, they have no diagnosed cancer, but they
Mhm.
have a genetic mutation that increases their risk. So I am removing both of their breasts. We call it prophylaxis. It's just
Okay.
something you take just in case,
In
but it's a
case.
surgery you do, for these women. But again, it all is in the backdrop of the risk of breast cancer. If the risk is high enough, based on
Mm.
the calculator, and in the scenario I just described based on a
Right.
genetic mutation, we need to do something about it, because people do die from breast cancer. Like,
Right.
even though I said it's curable,
Right.
when it's, at an advanced stage, it really is, it's terrifying, and
Right.
sometimes we can't do anything.
Wow. No, I mean, I think you're right. I think I'm getting to that point, if I'm honest and transparent, where, what does medication do? Obviously, I'm not one who's like, oh, just take this meds, down it, because I'm like, what are the side effects? Are these meds, the side effects of the meds, is it worse than even what I'm trying to cure? But at the same time, it depends on the situation,
That's
right?
very.
It's not one size fits all. It's almost like, okay, will this give me a better quality of life? Will this, if I did this plus change my lifestyle, could I eventually reduce the dosages? One thing people don't even know is there are different level of dosages to
Hmm.
medication. They
Hmm.
don't have to go straight out to the highest dosage,
Yep.
right? You probably just need to level off and things like that. So this is so important. We have a private question, and I want to ask the question. The person said, should there be any concern of cancer when someone has fibroadenoma?
Great question. So, fibroadenomas are very, very common. Okay, and that's one of the things that makes breast cancer screening and care sometimes hard, because the breast is just funky. I'm like, it's so interesting, the different types of lesions you can have in the
Mm,
breast that are not cancer, and this is where our pathologists are so important, because when a patient has something that they see on mammogram, or they feel something, we
mhm.
get more images, and then we get a biopsy. So we get tissue so that our pathologist can look under the microscope. You know, that biology class we all
Right,
hated? Some people are using it to save lives. And they
right,
can look
wow,
at the cells and say, are these crazy cells? We call them atypical. Or are they
right,
a normal variant, that, is just breast being funky?
right,
Fibroadenomas are one of those things that are breasts being funky. They
funky.
just, some people just have, we call them lumpy, bumpy breasts. It changes with your menses. Sometimes it's painful, sometimes it's bigger, then you get smaller. But they have a distinct appearance on imaging. And if there's any question, they get biopsied, but they do not increase your risk for cancer. They don't have to be removed. If someone is following and very clear about, if someone is following and is very clear that this is a fibroadenoma,
Right.
and you're getting your mammograms regularly. And that's why it's so
Woo.
important to get your mammograms regularly, because they can see what it was last year. They can
Right.
compare to this year.
Compare
Did
it.
it change? And they have, like, years of data, if you've been doing it for 10 years or longer. And so they can say this is a fibroadenoma, nothing to do. So it does not increase your risk for breast cancer. It's just a normal variant of the breast.
Wow, thank you so much. And please continue with the questions. If you want privacy, there's the question mark in the back that I'm at the bottom, where it comes directly to me, and I would ask it without saying names or anything like that. Please do trust that I would keep whatever is said on this live really confidential, because I know people really do want to learn. And I do appreciate everyone's, transparency in asking these questions, because that's why we're doing this. Okay. Another question says, I don't know if this has been talked about, but can you talk to women about birth control pills and breast cancer? Ooh,
Yeah, so we've done studies that, because this is an area that's of interest, right? But there have been several studies that have shown no correlation with breast
okay.
cancer. And so, it's one of those things where, take your OCPs, because it's not just for prevention of pregnancy. Some people have heavy periods. Some people take it for other reasons.
Mhm.
So I don't want you to feel like, oh, it can increase my risk of breast cancer. We just don't have that
Data.
information or that data to support that. So.
And research is good. We hear a lot of things. We hear a lot of things. And I think even growing up, I mean, I don't even, obviously, my parents didn't even think birth control pills, right? But then when I got to, I think, like high school, college, I started hearing more about, oh, birth control pills and cancer and things like that. And I was like,
Mhm.
wait, what? So that's a very good question, because that's conversation that's out there.
So I wanted to revisit the question of if oral contraceptives increase an individual's risk for breast cancer. And the answer is a little bit more nuanced. And so that's why I wanted to talk about it a little bit more. So while oral contraceptives can increase an individual's risk of breast cancer slightly, there are two major things to consider. The risk of breast cancer in the population of young women who would be using oral contraceptives is very low. And the second thing is that oral contraceptives have also been linked to a decreased risk of other cancers like ovarian cancers, endometrial cancers. So this really is a conversation you have to have with your clinician so you can talk about the risks and the benefits.
And that was Tommy Talks Med. She's an OBGYN. Amazing, 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 amazing. I'm gonna shout out some of my health people that I see on here.
I
Nice.
will say
Yes.
though, so if someone does get diagnosed with breast cancer, there are certain medications will tell you to stop, like
Okay.
OCPs, like hormone replacement therapies. These are things that we will tell you to get off because it can sort of impact how we treat an
Okay.
individual. So, yeah.
Okay. Thank you for that. Another question. When cancer has been detected, is
hmm
chemo the only successful treatment, or is it true that ordinary diet has cured it in history? Oof.
I love that question because I think that, we really need to address that. I don't know if anyone has seen this movie on um, this. There's this movie on Netflix. I don't know if someone has watched it, but it's about a girl who had a very treatable early cancer in her arm. It was a sarcoma, and she got into this world of therapy and diet and all of this stuff. And they wanted to treat her with chemotherapy because it was early stage,
Mhm.
and the individual just was like, I'm gonna drink my juices, I'm gonna do my coffee enemas, and I will be okay. And the cancer progressed through all of that.
Wow.
Now, what happens is we all hear these stories, these anecdotes. Someone just,
Mhm.
prayed, and I'm a Christian. I love Jesus,
Right.
but sometimes you
Absolutely.
just hear someone say someone prayed and they got healed. They didn't need surgery. They didn't need this. And but I'm of the mind that God gave us all of these, resources so
Yes.
we can work things up and this knowledge to really understand. So as you're doing your fasting and praying, on the other hand, be doing your research, be talking to your professionals, okay? So there are some cancers that are very lazy. We call them
Right.
indolent. They kind of don't progress or do anything
Right.
different. Some people may have those cancers and not do anything, and they're like, great, I'm good. But
Everybody's good.
but it doesn't mean that's the same cancer someone else has. There's some
Yeah.
that within a month they've progressed, they spread everywhere. There's nothing you can do,
Yeah.
and it's that variation that we as clinicians we see that individuals don't see because they're
Mm.
just having these one-off conversations.
Right.
And so I encourage people, yes, learn from other people's stories, other people's journeys, but when it comes to you, you have to know what is
Yeah.
good for
What do
you.
you do?
So again, it's funny, I see colonics and enema. Yes, that movie, this lady was having these coffee enemas,
uh,
right? Which to all of us is like, what? But and this is where we'll probably talk later about supporting people going through cancer.
mhm.
It can be incredibly scary,
Yeah.
and so people are maybe looking for something
Yeah.
out there. But I'll tell you, as a doctor, as a cancer doctor, um, there's nothing else out there. Let me just put it that way.
No.
There's nothing else out there. The systemic therapies that we've come up with, like chemotherapy, targeted therapy, immunotherapy, these
Mm.
are decades of research that has gotten us to this point where
Mm.
breast cancer is actually treatable, is curable, and people live longer
Longer.
and have better quality of life because we don't do the crazy surgeries we used to do back then. I love
Mm.
surgery, But the treatments we have now allows us to do even smaller surgeries that are not as disfiguring. So please trust your provider, trust your healthcare practitioner.
Right.
They know this information. Colonic enemas do not cure cancer. Diets don't cure cancer. They can
Mm.
help.
Help.
Even supplements can help. However, it needs to be with you receiving proven therapy. So that's my little spiel.
No, it's good. And we're going to talk a little later about even second opinions and things like that. So we're going to come back to it, but I want to get through to people's questions because I really do appreciate y'all for I really appreciate y'all for asking these questions because it's real. Another question, Triple A Mom 823 says, for a heterogeneous dense breast, is an automated whole breast ultrasound sufficient, or should a patient do a breast MRI?
So there
That's
about
for
a
like those thick breasts, right? Like
yeah,
when you feel it, you're like,
yeah.
yeah, okay.
And the reason why this is important is because I think it was earlier this year or last year, the guidelines changed to tell women that if well, first of all, radiologists after doing a mammogram have to tell a woman and note it that she has dense breasts, and that's
Mm,
because they found that women who have denser breasts are at a higher risk of having breast cancer. Now, what does that really mean? We don't know if it's the dense breast just obscures, cancer, and we can't find it easily until it's like much bigger, or if there's something about having dense breasts that actually increases your risk for having
mm,
breast cancer. We don't really know, but it was important enough to say the radiologist has to note it. They have to tell you that you have dense breasts. Now, whether you follow up with an ultrasound or you follow up with an MRI, it really is up to the radiologist. And for
okay.
that particular patient, that's why they didn't follow up the recommendation with do MRI, do ultrasound, because the thing with something like MRI, it sounds all catchy and nice, but it's very sensitive. It picks up
Mm,
random stuff in the breast,
yeah.
and it can lead to people having biopsies all day long. So that's why we're
Oh,
very careful to not just recommend MRI willy nilly in everybody. We recommend it for screening people that are at high risk. But even in someone who has dense breasts, it's not immediate. They may say an ultrasound is better, they may say an MRI is better. So it just depends on the individual scenario.
so an MRI may, because nothing is absolute, right? May create more, like it's almost like you open Pandora's box.
That's right.
And it's like, oh, I thought we saw this. Oh, we thought we saw this. Oh, now we go
Yes.
get a biopsy. Oh,
Yes.
and I
Yes.
don't even know if all of that is even good for the body.
Oh,
If I'm in radiation literally all day, every day, trying to rule out something. Oh,
yeah,
okay.
yeah. Good thing is the radiation risk is small. However, I think it's not great for people, right? To
Yeah.
have, because the fear is real. Then you're
Yeah.
like, oh, what else are they going to find? And we just, done the studies, looked at it from a population level standpoint. It's not worth it to just
Mm.
recommend it, blanket for everybody.
Nice. Okay. Thank you for that. Oh, he said my final question. No, there is no final questions. These are all really good questions. So please bring them on. As a result of cancer, a cut off breast can cause insecurities for women. What do you think about getting silicone slash breast addition surgery? Any dangers or advantages to that?
Yeah, so this is another thing that we've gotten so much better at
Mhm.
over time, reconstruction. So, removing a woman's breast is a big deal. That's, really for a lot of people the
We're going to
definition
talk
of
about
being
that.
a
Mhm.
woman. And so now there are a ton of reconstructive options from, if I don't remove all the breast, I only remove a portion, we can move tissue around. The plastic surgeon
Mhm.
can also do a reduction and a lift, really make them look like they're 16 years old. I mean, I look at the table after, the plastic surgery is done, I'm like, oh, I'm so jealous. Those look amazing.
Wow.
So if I remove all of the breast tissue, they can use implants, and we have, safe implants now that, even compared to what we used to have back in the day, they give excellent results, and they can really tailor to your body type. And then we also have people that want to use their own tissue. So they can do that
Mm.
tummy tuck at the same time, get tissue from your abdomen, put it in your breast. And they're extremely, extremely talented plastic surgeons that will do my cases with me jointly. So once
Oh
I do
wow.
my part, they do their part right after. Afterwards, patients may require, a few revisions, but ultimately the results are excellent, and so that really addresses the insecurity. And but it's good for women to know this, because
Yes.
instead of being afraid that, oh, I don't want to get screening for breast cancer, what if they find something, what, you have to remove all of my breast? Like, we thought about this for
Right.
decades, and so
Wow.
there's people are addressing every single issue. We
Hmm.
have body image specialists that talk to women about their body, help them sort of come to terms with losing their breasts. We have people that tattoo nipples on. You can
Yes, I've
create
seen
nipples,
I've seen that.
so there's like so many options out there.
And I mean, this is great segue to what I was going to talk to next, right? Is that healthcare as a whole has improved tremendously. Like 10 years ago, even I think 5 years ago, to what you health professionals are doing today, it's almost night and day. Doesn't remove the fear, doesn't remove the big scary word. It doesn't remove it. However, I almost see, and I think maybe because I'm in healthcare, so I do treat patients that have gone through like cancer or anything like that. I see a little bit of hope. I see that the research is bringing hope to us, where patients are living longer and they're like, okay, they're on their medication, send them to physical therapy, let's get their endurance up, let's get this, teach them dress, all of that. Even to OT, where they're working on like dressing, putting on their bra, stuff in their bra, like all of that. It's so, I think it's amazing. Still scary. I don't want to take that away. Still scary, but something that I personally dealt with was a colleague of mine who had breast cancer, but I didn't know her when she was first diagnosed. I kind of knew her, I think, the last 2 years before she passed away. And she ended up getting a double mastectomy, and then went to this, I think, tattoo plastic surgeon in Dallas. And
Mhm.
her nipples, like, I'm that person where I'm like, show me your nipples, because I would tell you if it's looking like this and should be looking like this. And like, of course she shared. I was just like, those are
It's good.
I I was like, and I think that was part of her body image. She ended up getting like a tummy tuck. She just did her body, and she was like, well, if I'm gonna have cancer,
That's
I'm gonna
right.
make cancer pay for all of this. And I was just like,
Yeah.
but it was that body image part of it is real as a woman.
Hmm.
As a woman, we think our breasts, we think our hair. There's some parts of us that makes us women.
Yeah.
And when those parts are removed, it's almost scary that, will my spouse not see me as
Hmm.
a woman? Would other people not see me as a woman? So I'm
Hmm.
glad you touched on the different resources that are in place, and
Hmm.
that you healthcare clinicians are thinking about
Yep.
all those different aspects. That's huge. Oh, final question. You don't have to write final question.
Yep.
All right, he says, who comes in the room first for the case? You or the plastic surgeon? Besides God and maybe teachers, I generally think you guys are next. Shout out to you.
Thank you. That is so encouraging. Really
Yes.
appreciate that. But to answer the question, most of the time, well, we're always there at the start of the case. Sometimes we start together. If they're
Okay.
doing the other side and there's no cancer there, they
Mhm.
can work on that. Sometimes if we're also doing the belly, where we're going to move tissue from the belly to the breast, we start together. But these cases are my cases. I just have the plastic surgeon on there for the reconstruction, but it's a cancer case, first and foremost.
You the boss.
That's right.
Period.
I call the shots.
You call the shots. So when does a patient typically get to you? Is it they get diagnosed with cancer, and God forbid, I'm gonna be transparent, right? Someone says, "Oh, I go to my OB, they say you're high risk." I'm like, take them today. I
Yeah.
they can go, you know.
Yeah.
Is that when do they get that option of when they can come see you, or is it when it's gotten to a certain level, it's when surgery is kind of brought up?
No, so that's a great question. Like, where along the screening diagnosis timeline do
Right.
you see a surgeon? So it
Hmm.
really just depends. It's highly tied to a couple things. So you touched on the risk part of it. So where I work, we have a very nice cancer prevention department where someone who, for any reason, is deemed high risk gets to have a discussion with the specialist who talks them through their options. Okay, if the person is interested in doing what we call a risk reduction mastectomy, then they refer them to me, and then I talk to
Okay.
them about what the benefits of removing their breasts are. But what we also talk about what some certain scenarios where you don't have to remove the breast. I know all of us think if you just hear remove
You can take you
it.
can have it.
But
I don't want it. You
I
can
would
have it.
encourage you that we know enough about breast cancer where we can
Mhm.
really inform you so you can make a good decision. And we call it shared decision making. We don't always jump to let's just remove the breast, but it's a conversation and we have time to have the conversation
Mhm.
because guess what? If you're high risk, you're going to be getting screening. And so
Right.
if we see anything, we're going to see anything like at its smallest. Okay. And so
Okay.
even at that point, it's very treatable. In terms of someone who's average risk, it really depends on the pathology. Okay. If the person undergoes a biopsy, say they saw a lesion, a lump, a mass, some calcifications,
Mhm.
and that shows either a tibia, which is not quite cancer, but it's just funky looking cells,
Yeah.
or it's a pre-invasive lesion, so really early type of breast cancer, or it's invasive breast cancer. Then at that point they're sending them to us. So typically what happens is people get their screening mammogram in the community, they biopsy something, it's cancer, they send them to where I work, we redo all of the images, and we also look at the lymph nodes. So this is something a lot of people don't know.
Mhm.
When we think about surgery for breast cancer, we always think about the breast, the breast, the breast.
Right.
But
Right.
the cancer cells are so sneaky. The
Mhm.
way they get to the rest of the body is that they go to your
Mhm.
armpit for the most part. There are these lymph nodes, the ones that sort of grow up here when you have a cold. The cells go into these lymph nodes, and then they spread to the rest of the body. There's some lymph nodes in the chest area too.
Mhm.
And we also do surgery on those lymph nodes, and which comes as a shock to a lot of
Yeah.
people, And so, in terms of, once the pathologist diagnoses something on tissue, that's when they refer to me. We do all these images to make sure we know what we're looking at.
Mhm.
We don't always do a CT scan of the whole body to see if it's spread because a lot of the times it hasn't spread. It's all usually super early. And then we decide, what kind of surgery we're going to do on the breast and on the lymph nodes.
Wow. That's interesting you say, because having it being a shared conversation again, I think testament to where healthcare is now. Before, they'll just kind of get, let's just take it out, but now you can have an informed I guess treatment, or
Mm-hmm.
informed, I'm forgetting the word I'm trying to
Like
say,
just
but
decision, yeah.
decision, yes, where
Mm-hmm.
we're not just being so dramatic so quickly.
Mm-hmm.
Someone said, can someone breastfeed after she's had a mastectomy? Good question.
That's a great question. So,
Yeah.
a lot of the times, if the cancer is just in one breast, they would have done mastectomy of that one breast. They cannot breastfeed on that one breast, but they can
Mm,
breastfeed on the other side. Okay?
okay.
Because what essentially happens when we do a mastectomy is we're removing all of the breast tissue, all
Mm,
of the ducts that make milk, all of that, comes out. In some cases, we can preserve the nipple. In some cases, we don't. So even if someone has what we call a nipple-sparing mastectomy, all of the ducts that actually make the milk is gone. So
gone.
they
Okay.
cannot breastfeed on that breast. However, they can always breastfeed on the other side, and that's why some patients say are very comfortable just doing the one side, which we recommend. We don't have to kill everything,
Yeah,
it's
yeah.
nice to have your natural breast. And some women really are interested in breastfeeding and they reserve the other breast.
Oh, that was a very, very good question. I didn't even think
Yeah,
about that.
yeah.
For those that are following your girl Tommy page, please go follow the Health Help with Dr. T. This page, we're waiting to get to 1,000 so we can do our lives on there. But please, so that you don't miss out on upcoming lives and previous lives, please go join the Health Help with Dr. T. Okay, that was very good. I want to talk a little bit about second opinions, right? Someone feels, and there's many ways to know if you have breast cancer, right? Or to even check yourself. Like we'll talk a little bit about how to check yourself. We talked about mammograms, things like that. But let's say someone finds a lump or whatever the case may be, and they go see their OBGYN. The OBGYN does all this stuff. They go see a surgeon, someone like you, and they just feel like there's too much. And it can be overwhelming at first, right? With all this information thrown at you, do you recommend someone to get a second opinion? Or do you feel like for patients, it could be much more overwhelming, confusing? Now, this person said this one is now saying this. Like, what do I do? What do you feel is the best practice?
Right, right. So let's back up a little bit because you started with something that I think is so important.
Okay.
You said check yourself. I
Yeah.
cannot emphasize that enough.
Mm.
Know your breasts. I mean,
Mm.
feel them, touch them, tell your partner to touch them. Everybody in the house needs to know those breasts because if
Yeah.
anything changes, you want to get on it. And the change is not always a lump. Sometimes the
Mm.
nipples just go like you're just look funny.
Right.
One may be flat for some reason, newly flat. Some people have flat nipples all their lives. Sometimes it's just red skin
Mm.
and just one of the breasts. Sometimes it's just swollen. There's not one particular lump. It's just swollen. So these are all signs, skin changes, that, you could look at and say, something's different. I need to
Something's off.
pursue this. And then you go straight to your, healthcare provider. Some people are not always familiar with these changes and they're like, oh, let's just watch and wait. Don't watch and wait for more than 2 weeks. Find somebody else.
Oh,
So I really wanted to touch that because it's
wow.
critical. So many, especially young women, have had their lives
Mm.
saved that way because they just said something doesn't look right. I need to touch base with somebody. So there's that, and then second opinions. I welcome them. I don't mind them, even when patients come to see me and they're like, you're real nice and everything, but I'm gonna find somebody else. I'm like, be my guest.
Right.
Because at
Go.
the end of the day, for me, what's most important is that you get the treatment
Yeah.
that you need.
Right.
Sometimes it's just, a mismatch in terms of personality. Sometimes people
Mm.
don't feel comfortable. As, Black women, Black individuals, there's a lot of distrust of the medical community. So sometimes they're seeing my Caucasian colleagues and they're just not, they don't feel
Yeah.
comfortable. And they're like, I want to see a Black surgeon.
Yeah.
I think it's absolutely fine. But what I will say is, really tease apart, what the provider is trying to recommend.
Mm.
If they're telling you that this is evidence based,
Please.
there's data driving this, they're able to show you the data.
Mhm.
I would really sort of caution against sort of shopping for people to do what you want to do. I
Yeah.
mean, it's your decision at the end of the day, but if they're telling you this is the data that we have that saves lives, I would certainly be open minded. Try to find somebody else if that'll make you feel better. But when they start saying the same thing and then you're going for a third or fourth or fifth opinion, then it gets a little bit like, well, people just
You're
want to
not
do what's
ready.
best for you, so.
Right. Very good answer. Thank you for that. Question for postmenopausal patients who want to get on hormone replacement therapy. How would one approach the concern of breast cancer risk in addition to risk stratification and getting routine mammograms? Ooh, that's a doctor talking. Because
I
first of
know.
all, Doctor
It's a
Triple A
lot.
Mom 823. I need you to write this in layman's terms. No, I'm
There's a
joking.
lot of doctor words in there.
That's
No,
a
I
lot of doctor
completely
words in there.
agree.
So, Dr. T, the surgeon, I need you to break down what she's asking
That's right.
and then help us answer, please, doctor.
Yes, yes. No, this is an incredibly important question. So when women get older, like I said, their ovaries stop making estrogen. Estrogen makes us feel good. Estrogen,
Mm,
keeps the hot flashes away. It helps control our cardiovascular system. A lot of things are associated with estrogen, right? But when our ovaries start to shrink and like, I don't want to say shrivel, but like when they just start to grow older, they stop making this estrogen and we start having hot flashes. People
mm,
get dizzy, they can't focus. Um, so what happened is people started developing synthetic hormones like estrogen, progesterone to help support women through what we call perimenopause or menopause, right?
mhm,
And unfortunately, there was a study that was done several decades ago that showed that this had a significantly increased risk of breast cancer. And that got everybody all scared. Everybody said, do not take hormone replacement therapy, it causes breast cancer. So many women essentially were suffering through their menopausal symptoms.
mm,
However, they did a new analysis, looked at the data again. They've had additional studies that have shown the well that actually, the risk is not that high compared to the general population. And
mm,
so more recently, they're starting to say it's okay to take certain types of hormone replacement therapies. Okay.
mhm.
And so that's why it's really important to talk with your clinician. And I love that they followed it up with risk stratification. So you have to understand what your risk is. Are you an
Yeah.
average population type of person? Or do you have a higher risk? In which case they may recommend other medications. It's not just hormone replacement therapy. There are other medicines that we can use to sort of combat these symptoms. And then, of course, tied to that with getting your routine screening. So if anything shows up, they can pick it up. But it's not how we used to be back in the day where we just said,
Mm.
stay off the hormone replacement therapy,
Okay.
but now we're more open to it as long as we're, checking you and we understand your background risk. There are better formulations now. There's even vaginal estrogen that also works well, but it's not absorbed as much as the one you take with the via the pill. And so there are a lot of options now. And so the most important thing is to bring it up to your clinician if you're having challenges.
Ooh,
Yeah, it's a heavy one.
that's a heavy one.
And it's
But
coming
it's
for us all. We're all
it's
gonna grow old.
I was like, as women, oh, that's gonna be a whole nother live. I'm gonna do a live about just venting as women and what we go through as women. Okay, so I have a private question. And it says, what could be causing this recent uptick in cases? Is it more testing resources, environmental factors, etc.? Um, and then okay, that's question one. There's two questions. So let's do one question, then I'll ask the other question. Like,
Yeah,
what's the
so
update?
Yeah, so we've seen this in the news with
Yeah.
several types of cancers, right? Not just breast, colorectal. Everyone's like, what is
Hmm.
happening? Why is the,
Every
risk higher? Everyone's scared. Like, what is causing it? And it really is multifactorial.
mm,
Like they alluded to screening, right? Like we just have better technology and we can find these things earlier. And even the cancers that won't go on to become problems, we can find them earlier. So that's part of it. Part of it is also, the lifestyle and environmental factors. We're eating, foods that are a little bit more processed, and whether we
yeah.
like it or not, these things can cause our cells to go crazy. And so there's just multiple factors that we're living longer also, right? Like,
Yes.
before people were dying in the 60s, now we're living to 100. So you're going to have more people with cancer. And
Mhm.
so there's just multiple reasons. And that's why I think it's really important to, to understand your own risk because it could be coming from anywhere. But there's some things that we can define, like family history, if you've had any breast lesion, so there's some things we can quantify. There are some things we can't quantify, like, plastic in our in our plastic water bottles. Like,
Water bottles.
yeah, exactly. There are just some things we can't quantify, but we
Right.
know it's probably contributing in terms of environmental exposures.
Great, great. All right. Second question says, as an oncologist and educator, I would like to know your thoughts on the rise of cancer in Africa, particularly Nigeria. In 2022, the Global Cancer Observatory noted 1.2 million new cases with 756,000 deaths, and now is projected to be even more grim by 2030, with breast cancer taking the lead. Ooh, somebody's a researcher.
I know, I know. I'm like, you do global health because that is extremely specific, but I'm so glad they brought it up because
Mhm.
we all have, obligations. I grew up in Nigeria.
Yeah,
That's home. And
yeah,
so this is the progress we've made here. I want to see it made back home
there.
too.
Mm,
Because it's, this can happen to anybody.
yeah.
Unfortunately, it is increasing in Nigeria for all the reasons I mentioned. And when you think about environmental exposure,
Mhm.
there's not always a lot of regulations, right, in terms of what's put into food. Like even just getting petrol from the gas station, right? Like it just splatters on everybody
Yep.
sometimes. There's some processed plastic that we're using. Like there's just so many exposures that comes with modernization, and because it's not always regulated in other countries, it might be contributing to the higher risk. And my hope is that we can really, as a country, band together and address this because I know several friends whose parents died of cancer in Nigeria, and it was a decision between, do I pay my rent this month or do I pay for
Mhm.
my parents' cancer care? It is
Wow.
it is really sad. It
Wow.
is really demoralizing. But my hope is that the government, us, because we have, in my mind, an obligation to give back, that we can start to mobilize, and some people are already doing that. And so, this is a space that is really near and dear to my heart.
Right.
But yeah.
Yeah, that's a tough one because especially immigrants, we think about home and and just wanted to help people as a whole. Okay, second to last question. I'm going to take one more question, then I'm going to kind of round up with one of the things that I wanted to talk to you about. What are your thoughts about aluminum in deodorant and breast cancer risk? I know a lot of people who now use aluminum-free deodorant because of this concern.
Yeah.
My mom is like this. My mom's like, She takes all of that out. On the barbed wire, all of that. All of that is gone.
So I mean, it's a great question. I'm of the mind, control what you can control. If it makes you feel better to use aluminum-free deodorant, go for it. But I feel like there's lower hanging fruit like exercise, weight loss, eating right. I think those are like much lower hanging fruit versus changing your deodorant. So I would say change your deodorant, but don't miss that part also.
Okay. Oh, okay. So I want to round up with one, and this is almost a personal question, and if it's too personal, I completely understand because, like I don't prep anyone prior to this, but I want to get into your mind as um, a surgical breast oncologist. I think I said it in the wrong
Breast
order.
surgical
Breast
oncologist.
surgical oncologist. You see this every day. How does that impact you? Right? Do you, for your mental health, it's people's reality and it's just the reality of the world. How do you day to day do this with strength, with smiling? You have children, you have a husband, you have family. Like, how? Because it's so admirable. I say that. But at the same time, this scary thing you literally face day to day. So I just kind of wanted to get your thoughts about what gets you through it. How do you manage it? How do you escape it? What do you do? Let me ask that.
Yeah, I mean, that's a really great point. And it started hitting when, as I grew older, I started seeing my mates, right? Like
Wow.
people who were my age, people who were younger than me, getting breast cancer and seeing the impact on their families. Like, the C word is, rightfully
Real.
scary
Right.
because, I mean, we all think about our lives right now, right? We're so busy. Like, I can barely hop from one thing to the other. My kids
Mhm.
have piano, then they have baseball. Where in that do you fit cancer treatment?
Hmm.
Which is what our patients have to do. They
Yep.
have to come to the appointments. They're getting
Hmm.
chemotherapy. They have to be getting it sometimes weekly, sometimes
Wow.
every 2, 3 weeks. They have to deal with the side effects. Like
Wow.
in the middle of living this busy
Busy life.
life, I mean, and so it's really humbling to
Yeah.
just watch, and not to lie, some days it can really be depressing, right?
Right.
Um, but then I think what I know of how far we've come
Hmm.
in terms of cancer treatment options, how many lives are being saved because people are doing the work, learning
Hmm.
about this disease, and trying to cure patients, that gives me hope.
Hmm.
And I feel like a conduit. Like, I just bring the message to
Yeah.
my patients and say there's hope.
Wow.
So I feel incredibly privileged to do that. And also, it
Wow.
gives me gratitude, for every moment, every
Yeah.
second. And my twin, I have to give her a shout out. Sometimes she'll be like, Taiwo just wants to just live life. I'm like, yeah, because some people can't do it.
Yeah. Yeah.
And so it really gives me, appreciation for every second, every moment that we
Hmm.
have with our loved ones, with our family, like my husband, my kids. I just like try to be in the moment with
In the
them because
moment.
everything can change in
Yeah.
like after one mammogram. And I
Yeah.
have friends that have been through it. I've watched them balance everything. And so honestly, that's how I get through it. I
Yeah.
try to be the hope that they need, and I also in my own personal life appreciate every minute. So
Awesome. That is great. I would tell you one thing you've given, if you haven't given hope to anyone tonight, you've given me hope. Like you breaking down, educating, giving all this information, it is not as scary. It's almost like, okay, there is light at the end of the tunnel, and I will be I do this health hub, and I think I have to hold myself accountable, right? I've been shying away from a mammogram, like, who I'm about to turn. I ain't gonna say what I'm about to turn because y'all not about to quote me on this. I'm getting younger. I'm not getting older, but I'm like, okay, my birthday month, that's what I'm going to do.
hmm
But you've given me so much hope. I didn't even think, not that I didn't think I was going to learn from this. Obviously, I knew I would, but I didn't think I was going to get hope from it. And so I really do thank you. I appreciate you, the work that you do day in, day out, the lives that you're saving. You're truly, truly a superhero. So thank you so much. And even taking the time to do the health hub. Like, what time do you have? You were operating earlier today. Well, I'm going to do the health hub down at 8:30, but I don't take this for granted. And I hope before every live, I do pray that this information does get out to people so that people can be knowledgeable and take something from it. So, and I definitely have, and I hope our audience have too. Thank you all so much for showing up. Thank you to the real Dr.T for being on this live. I'm so appreciative. Thank you so much. I hope you've had fun. I hope it was good.
Of course. Thank you for having me. I mean, the work you're doing is incredible. It
Thank
is
you.
not easy. I know how much legwork you're doing,
Yes,
to make
yes,
this a reality. So you
yes.
keep up the great work.
Thank
We
you.
appreciate it.
Thank
This is an incredible platform. So thank you
Thank
for
you.
inviting me.
Thank you so much. We'll definitely have you back on a because there's so much more, right? We did even scratched the surface. There's so much more. And I don't want it to just be October where we talk about it. It happens throughout the year. Women are getting diagnosed daily. So we're definitely going to have you back on. We're going to talk more and just get into, there's some good parts, there's some sad parts, just kind of balance it all. But thank you so much, Dr. T, for joining us. I truly appreciate it. Thank you, everyone, for joining. This has been great. This has been awesome. You guys have a blessed night and a wonderful week. Please join the Health Help with Dr. T. Go on YouTube and subscribe, please. This will be uploaded to YouTube.